Welcome back to the podcast. In this episode, we're going to be speaking about pre-hospital burns with Krissie Stiles. So in the conversation, we're going to really examine the prevalence, causes, classification of burns, and indeed let's explore the physiology and indeed some of the complications of burns. But what we're also going to do is look at the evidence-based management and also the priorities like assessment, fluid resuscitation, airway support, pain management, cooling, and safe transportation. Then we're going to examine the complications, prevention strategies, some of the coordinations that's necessary with burn centres, the psychological impacts on patients and families, and the continuum of care and rehabilitation. Finally, we're going to look at the training requirements, quality improvement processes, and indeed some memorable and challenging cases that our guest has treated. It's just worth saying before I introduce our guest that this is going to be split into two parts, this podcast, because there is so much content here. We're going to approach the first part and just look at some of the scene setting around pre-hospital burns, and then we're going to dig into some more content on part two. So joining us to delve into this topic and content is Krissie Stiles. Krissie is a nurse with burns and plastic surgery qualifications since 2003. She also has an MSc in burn care since 2019. She has led quality improvement projects, developing clinical practice guidelines and patient safety and projects across different domains. Krissie's founded the British Burn Association Pre-Hospital Specialist Interest Group and has also collaborated across various specialities, including award-winning programs such as the Burns Game and Saving Lives Is Not Enough report. So Krissie is an advocate for patient voices. She's also received awards for outstanding patient care, innovation in care, and effective burn care, and is an ambassador of Children Burns Trust. Welcome, Krissie, to the podcast.
Oh, thank you so much. It's lovely to be here.
It's great to have you with us, actually. Krissie, I just wondered if we could just start with just looking at the prevalence of burn injuries in pre-hospital care. How much does it sort of vary across regions and populations?
So, to be honest, most burns happen out of hospital. If they're happening in hospital, then we're in big trouble. But that happens too. So really, it really does fall into the domain of pre-hospital care professionals to look after the initial impact of burns. So globally, obviously, burns pose a massive burden. There's about 180,000 deaths a year and 9 million new burn injuries annually. Children tend to be the most presenting patient population, about 42%, and young children under 5 are the ones that are most prevalent. In the UK, however, so specific to us, the data tells us that it's about 250,000 people in the UK will sustain burn injuries each year. Not all of those get as far as A&E. Some are treated locally or self-treat. So about 130,000 will get to emergency departments. And just bear in mind that burns pose only 1% of the total ED trauma workload. So we don't see them very often in pre-hospital emergency department settings. Out of those thousands and thousands of patients, only 11,000 or so are getting as far as the specialist burn services. Children are still half of the population that we treat with severe burn injuries. Boys are more affected than girls. And across England and Wales, nearly 4,000 children under 15 are admitted to hospitals with burn injuries each year. So those are the numbers. But what our data also tells us is that the populations that are based in the lower socioeconomic groups have a much higher prevalence of burn injuries as well. So we need to make sure that we look out for the more vulnerable pockets of our society too.
I think that's true across different trauma, just that social deprivation maps onto trauma disparately, actually. But the reason why I wanted to have this conversation with you, like you said, it constitutes only 1% of the workload, but is one of the most challenging presentations I think I've ever sort of seen in pre-hospital care, because especially when it's pediatric burns, because a lot of times you have a fully conscious child, they're screaming in pain. There's multiple challenges. One would be access, and we'll go through some of the challenges shortly, but pain management, fluid differentiation, and indeed volume, but also, airway considerations, and then, like you said, specialist care. Lots of things to go at. But they really are a challenging case presentation. Could I get you to speak to some of the commonest causes of burn injuries in pre-hospital care?
So, burns is actually an umbrella term for multiple mechanisms of this particular trauma. So, burn injuries can happen as a result of a flame or a scald, steam, contact with hot surfaces, electrical, chemical, friction, radiation, or cold injury. So, all of these are potentials that pre-hospital care practitioners can come across. But in both adults and children, actually, the commonest uh, place where burn injuries happen is in our homes. So in kids, about 80% of all accidents will happen in the home, and 50% of those happen in the kitchen. So actually, we are in our safest places where we feel most comfortable, and that is where we tend to get burned. So majority of burns in children and adults are actually as a result of a scald injury, and they represent about 43% of all acute burn injuries. So scalds are as a result of hot liquid being spilt by accident on a person. So for children with severe burns, your top three causes of burn injuries are scald, flame, and contact with a hot surface. Whereas in adults, the severe burn injury, the top three causes are flame, scald, and contact. So we're all kind of hovering around the most frequently presenting types of injuries. The more shocking statistic, and certainly as an ambassador for the Children's Burns Trust, for us is that 64% of children, and those are mainly kids under 5, so 64% of children with burns will require hospital admission as a result of a hot drink scald. So it's not their hot drink, it's usually the parents' hot drink, and yet these are the numbers of children that are actually getting injured. On the kind of relief side, most burn injuries are non-complex. So 90% of burns that we would see in the specialist services are non-complex burns. They're also unintentional, and they're either accidental or through carelessness or inattention. For adult patients, and you being paramedic, you will attest to this, a drug or alcohol is involved in about 15% of cases as a contributing factor to burn injuries as well. From the point of view which body parts we see most frequently injured, it's probably hands. So hands and arms are the most frequently injured, followed by head and legs.
Really interesting, actually, especially within pediatrics, like we said, the digits, arms coming out, and just the appropriation of risk or lack of understanding of, like, say, hot surfaces. I think, again, sorry to sort of double click on this, but it is one of the things which, and case presentations, which is really quite common, is pulling hot drinks from tables and or coffee tables onto themselves. Obviously, you're not understanding that there is and I'm almost paranoid about hot drinks near any kind of service near children, because having been
Good.
to some, yeah, horrific. And another one of my revelations is with adult burns is that I think people negate the danger of smoke, because smoke can burn at a plus 120 degrees Celsius. It's obviously full of toxic chemicals as well, and that plays a part. But the vicarious burn injury are caused by smokes, and so not really contact with flame at all, but inhalation of toxic hot smoke, which can cause inflammation and indeed burn injuries down the whole respiratory tree.
Mm.
Is I think it was a revelation to me. Could I get you to speak to the classification, or just some of the common classification systems used to assess burn severity within pre-hospital care?
So ultimately, we must remember that however impactful the first impression of the patient with a burn might be for you as an attending clinician, burns are trauma, and they have to be approached as such. So your assessment and treatment must always be applied to a trauma casualty who happens to have burns, not a burn casualty with injuries. This is often the issue with especially severe burn injuries. Life-threatening non-burn injuries may be missed because the obvious and serious burn injury can be very confronting, very distracting for the attending clinician. Burn injury itself might also be associated with obvious and concealed other injuries and is a potential distractor for other more immediately life-threatening problems. So the initial approach is always as part of your ATLS trauma surveys. So you look at a patient with a burn injury and they will fall into one of the three categories. They either have an isolated burn injury, or they have a burn with an obvious other injury. So it's polytrauma plus burn. Or you have a burn with a concealed additional injury. And those are the latter one, are the really, really tricky ones. So you need to take a systematic approach to trauma to identify and treat life-threatening injuries as you find them. So that's your primary survey. And then it's followed by a systematic evaluation of the burn injury itself. And you would estimate the extent of the surface area, the depth of the burn, and the distribution of the burn injury. So from the point of view of estimation of severity of the burn, we tend to look at the size of the burn. So it's estimated as percentage total body surface area burned. For that, we have multiple methods because we like to confuse non-specialist providers. So there is the Palmer surface method, which utilizes patient's palm with fingers as an equal to 1% of their body surface area. So if you look at the patient's palm with their fingers and think, okay, that area there is their 1%, so how significant is this burn injury? And then you can hopefully estimate the size of the burn that you're looking at. There is also Wallace's rule of nines, which actually, in my experience, is the one that's preferred by pre-hospital community. It breaks down the whole body into areas of 9, and each part as a value, you can then add it up. So one upper limb is 9, the other upper limb is 9, legs are 18. So one leg is 18, the other leg is 18. So everything is a value of 9, and you can just very, very quickly add up. Unfortunately, it's not overly accurate in children, and you have to be very careful to use the pediatric ruler to calculate accurately the estimation of burn size if you are using Wallace's rule of nines. But for adults, it's good. The gold standard is Lund and Browder chart, and that chart is got multiple various values. It allows the changes in body shape from baby through to adulthood. So it comes in various different charting versions from baby, 2-year-old, 5-year-old, 10-year-old, and then adult. Again, it takes time, and it's time consuming. It can be confusing because anterior thigh in an adult is 4 3/4. And, the 3/4, on a night shift, try working that out. It can be complex. So I would say that I would utilize London Browder chart as kind of my final resource rather than the initial method of estimation. So use whatever method that tends to come to your head and inside out, and you could do it at 2 a.m. on a night shift. The other version of estimating size that military actually have introduced is the serial halving method. And nobody can get this one wrong. So all of me is 100%, half of me is 50, half of that is 25, and you just keep halving until you get to the approximation of the burn extent that you're looking at. So all of these methods are available. Just choose the one that works for you best. So that's the estimation of burn size. There's also a connotation of burn depth. I don't personally believe that in a pre-hospital setting, burn depth matters because you're not going to change anything in your initial approach or treatment based on your assessment that the burn is superficial or it's really deep. That's more for the surgeons and the burn services. But it gives you a really good indication of severity, which is what we're talking about. So if you are able to guesstimate the depth of the burn, they are classified into being superficial, so that's your erythema, looks like sunburn, hurts like hell. Partial thickness, the one that blisters and hurts quite a bit and oozes everywhere. Deep dermal, which has got fixed red staining that actually has coagulated capillaries, so the damage is done, and potentially some of the nerve damage too. And full thickness that hopefully none of us can miss, because they're charred, they're leathery, there's no sensation, they feel tight, and get constricted over time. So that's the depth of burn. So really, in the pre-hospital community, you kind of want to see and assess your patient, whether can they feel things or not? Is it blistered or not? Is it charred or not? Is it oozy or not? Basics like that will give you an idea of it's kind of a really deep burn, or it's kind of moderately deep, or it's a mixed depth burn, and then you can make your decisions as to whether you progress it further and they need transfer, whether they can stay locally and be treated by their local GP or practice nurse, for example. So depth of burns gives a richer information to assessment of severity, but usually there are other connotations like the size, location, the age of patients, the other consideration that we can discuss that affect that severity for patients. The other last little bit that also might be worth bearing in mind is whether the burn is circumferential. So does it go all the way around, say, a limb, torso, neck, or a digit of a patient? Circumferential distribution in itself is not necessarily a horrible, awful, terribly severe thing. But if you have a deep burn that goes all the way around the limb, you now know that through general tissue injury processes, the inflammation is going to start and the swelling is going to start. And very quickly, that very taut, deep burn is not going to allow the tissues to expand. So you're going to start to compromise your internal organs, internal structures, blood vessels, nerve endings, muscle, and you're going to end up in the compartment syndrome type picture. So that's for limbs and digits. For neck and torso, it can have real connotations to patients' ability to breathe and expand their chest. In children, and the neck burns, if they go circumferentially or even partly occluding the neck, you need to be very aware that as soon as that swelling happens, it can go push the swelling internally and occlude their airway. So always being aware of size of burn, a bit aware of the depth of burn, but also aware of, is it circumferential or not?
Listen, that's fantastic. Krissie, could I get you to speak to the body's physiological response to burn injury and how it differs from other types of trauma? You know, we do see this almost systemic inflammatory response to systemic and local response, really. Could I get you to sort of unpack that for listeners?
I mean, that's a really packed question, isn't it?
Yeah, it is. It is.
So, right, let's just see if I can do this. Burns are different to trauma
Yeah.
because they behave in their own very independent and unique way. So, firstly and foremost, we must remember that burns affect skin. Injury to skin, and skin being the largest organ in our body that has many, many major functions. So skin is responsible for control of fluid loss, regulation of body temperature. It offers physical protection against mechanical and chemical and thermal insults on our body. It's a physical barrier against infection and microbial invasion. It has massive involvement in immune activity. It has metabolic function. It synthesizes vitamin D for us. It's a massive sensory interface, allowing us to feel our environment and react to our environment. And more importantly, for burn survivors, it's a psychosocial interface. It's something that once healed can result in a scar that then becomes socially obvious and socially uncomfortable for many burn survivors. So we are looking after the largest organ in our body that has now injured. It's lost its protective functions. It potentially cannot work in the same way because the burn will interfere with every one of those major functions. So there is the local response. Where is the wounding? So you're having to consider the wound, the open wound, the oozy wound, the depth of the injury that we've just discussed, the size, the extent of that injury. Locally, there are processes that happen that were described by a surgeon from Birmingham, Jackson, who coined the concept of burn depth progression and zones of injury that he described as part of his research. And he suggested that where the burn injury happens, there are three central zones that are all dynamic and all interactive and are potentially malleable by our initial interventions. So there is the zone of coagulation. That's the area that's where the direct damage has happened. It's characterized by irreversible necrosis and complete destruction of tissue. So that's very central 3D impact of the burn injury. The zone surrounding that is the zone of stasis. The tissue is damaged, but there is some impaired vasculature and perfusion. But the tissue viability, whilst it's under threat, we can potentially recover it with first aid measures, with fluid resuscitation, appropriate atraumatic wound care, and administering appropriate pain relief so that we de-stress the system off from that kind of very painful stimulus. And then the third zone is the outer zone, the hyperemic area, where it's okay, it appears maybe superficially injured, it may be red and hyperemic, but it's not under threat and it will recover by itself. So it's that most painful area of the burn potentially, but actually can recover by itself. So those are the three zones. And I already said that we can do things to reverse some of the damage. There's also, apart from the local response, there is the general response to burn injury. And I will be speaking specifically to major burns. So a major burn that approaches over 20% surface area in adults and over 10% surface area in children starts off clinically significant systemic effects. So you kick off a massive systemic inflammatory response that is no longer confined to the local injury, but becomes systemic with impacts on organs and tissues that are distant from the burn injury itself. So say you've got a burn injury to bilateral legs, circumferential bilateral legs, so you've got 18 and 18, 36% burn in an adult, you will have systemic edema to the rest of the body. So if you're, say, taking considerations for your A and B, so airway breathing in your ATLS survey, seeing the fact that patient has got a burn that's over 20% surface area, you now know that actually they're going to have this inflammatory drive across the rest of their body that might actually compromise their breathing in the next couple of hours. So needing to be aware of that general response that can present in big burns as well is massive for pre-hospital care. And of course, there are systemic effects that affect the acute severe burn injuries. And they're multiple. There is the vascular response from increased vascular permeability, which causes that significant edema, but also it allows the transfer of, big molecules like albumin all of a sudden finds itself where it doesn't belong in extravascular spaces that draws fluid towards itself, hence the edema. You have impact on the heart. So whilst the cardiac output is initially reduced in the first initial hours of the burn injury, you have decreased blood volume and venous return. You obviously have increased pulmonary systemic vascular resistance. All of these things happen because of the increased level of catecholamines jumping around in the body, all the stress enzymes and parameters. But between 24 48 hours after the burn injury, you kick the patient into hyperdynamic state. So they have reduced peripheral resistance, they have increased oxygen consumption and increased cardiac output. So you see their heart rate double, you see their respiratory rate double. They chomp through medication like drugs, analgesia, sedation, much faster than any other trauma patient would be. So if you think about your patient in SIRS, that's what the burn patient becomes, but they don't just stay in that state for a short period of time. This can last for months and sometimes years, that hyperdynamic drive. it can affect their lungs. And obviously, you mentioned already the smoke inhalation component, not just the smoke particles, the debris that can end up in the patient's lungs, but also the chemical components that can have systemic toxicity on the rest of the patient's body. So you actually could have this smoke inhalation that can damage lungs. So you have skin as well as lung to manage at the same time. Kidneys can be affected. So acute kidney injury is massive in major burns. Usually it starts as a result of under resuscitation, or can also be secondary to compartment syndromes, or maybe later on as a result of sepsis once they're in ICU in the burns unit. Impacts on GI tract. So again, the edema does not discriminate. It goes to lungs. It can also go to gut. So you could have gut edema, you could have ischemia, you could have mucosal atrophy, and also bacterial translocation. So all of these happen within hours of the burn injury happening. For that reason, we start very early feeding through a nasogastric route to try and offset, to remind the gut that actually it's meant to be working, it's meant to be providing energy. So it actually offsets quite a lot of these elements, consequences of major burn, if we do early feeding very early on. And the metabolic response. So the hypermetabolic drive happens about 72 hours post-burn. You have a metabolic and catabolic response that develops that can persist for months and months, and like I said, years. The catabolic response is the most dangerous one for our patients because body preferentially uses muscle mass for energy source. So that's why we need to feed our patients. We need to give them additional protein load, and sometimes growth factors and additional things to substitutes and steroids and all sorts of things to try and build them up for all of the massive muscle loss that they sustain. And that catabolic response is responsible for that. So burn injury is massive. And as you see, it's very different to just to trauma.
Yeah, no, indeed. And as you said, it's multimodal. And the severity of even more sort of minor burns just compounds over time. And I think it kind of leads me quite nicely into this next question, actually, Krissie, around complications of burns. But one of the main things I've really struggled with burn injury, especially in an entrapped environment where there is maybe significant airway burns, but either circumferential or airway or neck burns and chest burns, is that what you're seeing isn't necessarily the fruition of the injury, the compounding inflammation over time. And actually it becomes harder when you're with this patient over 4 to 6 hours, where maybe in rural services where you've got to transfer this patient over 4 to 6 hours, because you've got to almost in your mind think, right, what's the worst case scenario for this patient? Because I need to almost treat now for this spectrum of care, the spectrum of inflammation, the spectrum of pain management requirements, the spectrum of fluid requirements over time, because things change, and actually the challenge fundamentally within pre-hospital care is what you see now isn't necessarily the sequelae in 4 to 6 hours, and the burns patient is the archetypal example of that things characteristically get worse, but get worse in the worst areas, i.e. the airway, the chest expansion, just the nature of the burn. Could I get you to speak to some of the complications?
Yeah, I mean, I like the fact that you're thinking when you are with that casualty, what's the worst that can happen? And you totally have to have that approach because the worst will happen. It can happen because of the delay in access to services. So complications can be acute, and complications can be as a consequence of inappropriate treatment, over treatment, under treatment, in delaying access to appropriate care, and obviously as a result of the injury itself, as I've already alluded to, the multimodal impact, severe burns. So in the acute stages, if we go through the whole A to E assessment, for airway, you have one of the major significant complications is the loss of the airway. It is progressive, so you need to make sure you start thinking about how am I going to secure this airway, because if the edema is progressing, okay, you potentially are going to lose it. And if it's not you, then you need to make sure that you've got a colleague and advanced skill set nearby that potentially can support that for that patient. Under B, you've got your smoke inhalation that can impair gas exchange and cause systemic toxicity. So potentially you have a patient who's got cyanide gas intoxication and won't get better unless we reverse it with an antidote treatment, for example. There are also the circumferential chest burns in adults or chest and abdominal burns in children that can potentially prevent their chest expansion. So whilst, yes, we've secured their airway, we're trying to bag them or trying to ventilate them, and it's not working, potentially they are at a need of a sclerotomy to improve their ventilation. For C, you have significant lack of sites for IV lines. You are dealing with potentially extensive burn injury. You might have leathery eschar that's constricting limbs, causing compartment syndrome. And you're trying to shove your lines in somewhere that's non-burnt area as per guidance. So that's a massive challenge for clinician at side. But for the patient themselves, if you have constricting circumferential limb burns, why not you as a clinician check the pulses, peripheral pulses? Yes, it's not technically life-saving assessment, but it can be done extremely quickly and will add important information about the status of your patient, about their limbs, and potential limb salvage for them in the future. Because if that limb is starting to become compromised, within 3 or 4 hours, the potential to reverse that flow that's currently being occluded is gone. So you need to appreciate, right, where can I convey that patient to in order to save their limbs? Gives you a very different understanding of what the consequences and complications of the burn injury can be. Under D, you have increased requirements for pain and sedative medication because of the hypermetabolic drive. There are also some causes of restlessness and maybe even decreased level of consciousness due to hypoxemia or carbon monoxide or cyanide poisoning. So you need to be very aware of the changing neurology within your patient and potentially that we've missed something, especially if they've come from a burn in an enclosed space where they lost consciousness and were rescued out of that environment. And finally, under E, you've got your kind of thermoregulatory properties of the skin that we've now lost. You have a massive open wound surface that is wet and oozy, and you patients who've lost integrity of their skin and cannot keep themselves warm. If they're sedated and anesthetized, they also won't be able to shiver to increase their metabolism to keep themselves warm. So we need to be very, very mindful of the fact that, I mean, we already know of the lethal triad and trauma. These are your patients. Burn patients will be in lethal triad because they will be hypothermic because of the loss of skin and all of the evaporative heat losses. So you need to make sure that you look after them and prevent any heat loss. So that's kind of A to E in the acute system. I also alluded to the fact that we're injuring our major organ, so skin, all the properties of skin. So once you've healed, for example, scar tissue doesn't tan, it'll burn. It will no longer be able to synthesize vitamin D, for example. It doesn't stretch, it doesn't behave in the same way that skin does. It is itchy, it is painful, it can crack. It obviously becomes a scar that people can see and pay negative attention to. It can be oversensitive or not sensitive at all. So you can have lack of sensation, or you can have pins and needles or shooting pains through the scar tissue that can be absolute nightmare to live with. So there's all these impairments on the patient's quality of life. So as you can see in the early stages, you have this massive internal organ, muscle, nerve damage that's potential. You've got the compartment syndrome potential. You have systemic toxicity potential. There's also the edema-related effects like airway edema, intra-abdominal hypertension, intra-abdominal compartment syndrome, limb compartment syndrome, all of these things that where edema progresses systemically, and all of a sudden you have a very, very sick patient who has a burn, but also now is on their route to multi-organ failure too. And the long-term consequences of the burn injury will be things like limb loss or digit loss. So it can result in an amputation, especially deep, deep burns or electrical burns specifically can be incredibly linked to limb loss. Scarring and disfigurement is inevitable in a burn injury that takes longer than 3 weeks to heal. And yes, we can treat it, but scars on their own have a very different typology, and they behave in a very different way depending where they are as well. And patients will experience loss of strength and function as a result of the fact that they've been immobile in a burns ICU bed for a long time, that they've deconditioned, they've lost muscle mass, they're not able to be as strong as they were, the function, that their limbs don't work in the same way, their joints might be affected by scar contractures. All of these can be managed over time, but the recovery takes months and years and takes a massive team to support the recovery of these consequences of severe burn.
So pivoting slightly and looking at, we actually spoke offline, Krissie, around just the lack of empirical evidence behind some of the key principles of burn management that we all almost hang our hats on, that we practice, and just this lack of robust evidence-based medicine. Could you kind of speak to that? Because I think it's not necessarily just a unique feature of burn management. It translates to a lot of pre-hospital care, actually. But could you speak to the fact that there is still a long way to go, and there's a real gap in the literature?
I mean, I'm sorry about that. I would love to say that we have like top-notch, high-level studies to support everything that we advocate for in pre-hospital burn care or even in hospital burn care, but it just doesn't exist. So a lot of the literature and guidance currently sits on the evidence, on expert committee reports or opinions of clinical experience of respected authorities or individuals. So yes, sometimes it is extrapolated from higher level evidence, but literally it's not that consistent, and it's not as present as we would like it to be. So certainly this is a challenge to the upcoming generations of paramedics and pre-hospital care practitioners and burn care practitioners, that actually, if you are interested in anything in burn care that you might find really confusing or feel like there isn't a definitive guidance, or you don't understand why this is the guidance, then do your own research. Go out there and find out and tell us all about it. Potentially you asking that question and you looking into it and delivering your own study might impact how we conduct our business in the next few years or decades. So definitely do that. I would say, though, that there have been developments, and unfortunately in burn care, as in trauma as well, most advances have been on the back of some massive event. So usually warfare and combat have driven innovation. Certainly in the plastic surgery and burns field, that's how it's happened. But our mortality rates have halved since the times of the Second World War. In the 1940s, 1950s, we were looking at our utmost outcome for our patients being survival. We needed to make them live. Well, that's no longer an issue because our patients are surviving some horrendous injuries. We are making them live because we have really moved on with our evidence base and our critical care and our early delivery of advanced skill sets at the time that the injury happens. But what we're now struggling with is, okay, now that we've made them live, oh my God, they're having to live with all of these consequences of burn injury that we are not fully enabled to support. So that's where most of the advances have been actually in burn care lately, is to do with the scar reconstruction, scar treatment, kind of the surgical reconstructive prowesses, different dermal substitutes that we can use to, instead of patients' own skin cells. All of these things have developed for us in burn care, but pre-hospital care very much follows your trauma approaches, your research that actually has gone into trauma per se rather than burns trauma as such. So there is very strong evidence, for example, for airway and inhalation injury management. So we have plenty of stuff now on burn size estimation and even fluid resuscitation. more recent developments, I say recent, but that's probably the last 10, 15 years now, further developments that we've seen have been to do with first aid, so burn cooling with water. We finally have a definitive guide as to the fact that it's 20 minutes water cooling that works, with thanks to many researchers like Layla Cuttle and Roy Kimball and Bron Griffin from Australia who've actually looked into this. So they've worked out that it's 20 minutes, it's not 10, it's not 30, it's 20 minutes that works. So we know how long to cool for. We also know that it's only effective within 3 hours after burn injury, all thanks to them. So we also know from the UK-based studies, so Hugh Wright and Mike Tyler from Stoke Mandeville and the Restore Research Group, they found out that actually if you do cool for 20 minutes, you can reduce the depth of the burn by 25%. So that's what water cooling does. And also the impact of the 20 minutes cooling from Fiona Wood and Dale Edgar, again in Australia, they've looked at, okay, so we're doing all this cooling and we know that local effects are happening, but what in the long term does it mean for our patients? And it means that we're not only reducing the burn depth and size by delivering cooling, but also we're reducing the severity of the burn, the need for surgery or a skin graft. Patients stay in hospital less. They don't stay in intensive care for as long. They're less likely to get infection and they're less likely to result in scars. So all of this research has come on since 2008 and has been absolutely instrumental in pushing our global practice in burns first aid. And yet, despite this evidence and despite it being in our guidance, still only 25% of all paramedics, 25 to 35 of all paramedics will deliver first aid when they attend a burn casualty with burns. And only 30% of all our patients who've had a burn present to the burn services having had first aid for their burn. So there is a discrepancy between the empirical evidence. We know why we do it. We know why we advocate it. It's not seemingly translating into practice. The other thing that has been moving forward is the chemical injury management protocols and the use of not only water for irrigation, not only isotonic solutions, but also these new and up and coming, not so new to be fair, but now in research and in our practice, amphoteric chelating washing solutions. So there's been quite a bit of research and it's starting to be embraced by the pre-hospital care community, and certainly the burn services have used these solutions to try and neutralize whether acid or alkali chemicals to make sure you just minimize the amount of washing that you're having to do for a chemical injury, but equally that you actually are halting the injury, especially for alkali burns, that it doesn't keep progressing through the tissues if you apply this far superior solution. So that's another thing. So overall, like I say, there's not much evidence for much of what we do, but there is some. And actually, I'm part of the Global Burns Research Priority Setting Partnership, which is a bit of a mouthful, but it's in a combination with the University of Bristol and James Lind Alliance, where we actually have done a massive study over the last couple of years, trying to establish the top 10 research priorities in global burn care. And that will set the tone for what burn clinicians as well as burn survivors and their carers feel are priorities for them in the future burns research. And hopefully for these up and coming clinicians in pre-hospital care and burn care, that might guide where you choose to poke your nose, what questions you can ask, because you know that all of these people have said, this is important to me. Can you please find out and make it happen?
Yeah, it's so important, isn't it? Actually, this patient and population consultation is super important. I submitted a few PhD proposals and and grant proposals, and it was the patient forum groups actually were something that I was guided to do, but I actually found extremely informative. It was around cardiac arrest actually, and actually coming face to face with a number of cardiac arrest survivors and about what was important to them. Because as you said, actually, with what it does is it funnels treatment into what actually truly matters for patients, which is quality of life. And like you said, it shifts from mortality to morbidity, and what quality of life in that morbidity and in that in the burn, in the scar tissue, in the, like you say, the day-to-day functioning of patients, and hopefully the rehabilitation of patients. How does that look? You're right, from the patient perspective. Can we just pivot slightly? We're almost finished for part one. We're gonna ask a few more questions,
Mhm.
and then go from there. I'm just going to break for a moment actually in this. Just Krissie, how are you feeling actually? Because what we can do is, yeah, we can go through now for part two slightly. I've got two more questions for part one, but then if you want, we can come back if it as in
It's
another
fine.
time.
I've got a call at 2:30, so
Yeah,
I can
that's
keep going
fine.
until 2:30, so
Yeah,
we can break
no,
and then
that's
reschedule,
fine.
whatever.
Yeah,
It's
yeah,
fine.
yeah, yeah. That's perfect. No, that's perfect. Let's do that. I've got one, two, three. I think what we'll do, yeah, we'll just go, yeah. I'll go for like I'll go for maybe I'll go for like four more questions and then we'll
Yeah,
come
just
into
keep
that.
going. It's fine.
Yeah,
Yeah.
yeah, awesome, 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 awesome. So my next question really, Krissie, is around the management or differentiation of management for pediatrics and elderly patients. One of my observations and extremely difficult challenges, and you can speak to this, is the the lack of intranasal as a route for pediatrics when it's very much advocated by institutions in hospital, but there's a lack of sort of intranasal access for ketamine and or morphine and or other opiates or MDMA antagonists just available to post-op clinicians. And like we said, the epitome of this is the screaming 4-year-old child that's poured a hot cup of coffee or a hot bowl of soup across their face and chest. They're absolutely in agony. IV access is near impossible because they're just wriggling, they're screaming, they're absolutely in pain. IO access is not necessary, is not either a consideration. IM access is great, but takes some time to work. And yeah, I always struggle with IM access because it's easy enough, but you never quite know where you are with analgesia in that place, and it does take, the absorption is a lot slower, and just intranasal access just seems so intuitive, and it's immediate access to the mucal membranes in the nose, and you almost know where you are with an agent. Could you speak to why we're not seeing that more within pre-hospital care, or indeed just what you see? Don't worry if you don't know, or there's not a definitive answer. And also with the elderly patient, one of the things I learned within critical care actually was be extremely careful with half dosing, actually, because there's a lot more fragile physiology involved. And actually, if you give the full whack of ketamine or the full whack of morphine or fentanyl, it could absolutely knock their physiology and their blood pressure off. So there's definitely subtle, different, nuanced approaches to both ends of the spectrum. Could I get you to speak to your thoughts?
Um, Yeah, I mean, this is such an interesting subject, actually, because we often talk about adults, but we forget that the demographic that actually gets burnt the most are children and elderly. And they are the trickier patients for us, as you describe, that screaming child that, they're never going to swallow anything, they're just going to be spat out. The intranasal route is absolutely awesome, but as you say, is not always available to your pre-hospital care clinicians. And that is frustrating because it is ever so effective. And regardless of the age demographic of the patient, if I am a patient who's in pain, I'm not going to listen to you. I'm not going to do as you tell me until you manage my pain, because pain is all I know right now. And you're not going to get on top of anything else with me or get me to do anything until that's managed. So analgesia is absolutely one of the massive priorities in burn care. You can't get to me to assess nothing, to take anything off until you've given me pain relief. And then I'm more compliant, then I'm more manageable. Then it's nicer for everyone to be around. So with pediatrics, definitely intranasal route is absolutely amazing. And I've had a lot of feedback from clinicians in emergency departments and pre-hospital care community how effective intranasal route is. So much so that I actually recently had a question from a clinician who said we had a child with a significant facial scald, which also went intranasally. And because they had this blistering of the mucosa intranasally, the clinician said, well, I gave them intranasal ketamine, but I wasn't sure if that's an effective route. There was a lot of discussion before we went to give it, like, would it work? Wouldn't it work? And please be reassured that it would work, because dermal, ultimately, it will still get through. So you're very unlikely to have deep, full thickness burn intranasally. So give it, do it. If you have it, please give it, because it's going to be your best asset that you can give the children who are in pain. From a overall kind of pathophysiology of the burn injury in children and elderly, children have much thinner skin than adults. Their dermal layers haven't developed yet. They haven't grown its thickness. So they end up having a much deeper burn than an adult for any given temperature. So if comparably you spilled that same pot of noodles onto yourself, you might have superficial redness, you might have a little bit of blistering. The child might have a deep dermal or full thickness burn, the same pot of noodles. And that's to do with the dermal thickness. For example, children, when you were talking about first aid administration, children are reliant on parents to do the right thing. So, and same with elderly. Elderly often live alone. If they have had an accident, there is a delay to somebody delivering first aid. So if the parent is not willing or doesn't know first aid, or if the elderly patient has, fallen and there's nobody around until the next morning, potentially their injuries are going to be worse because they wouldn't have had the kind of key essential interventions that can reverse the damage within their tissues. And remember that for children, and actually until recently, elderly were considered major burn at 10% surface area. So anything above 10% TBSA is a major burn that requires fluid resuscitation and full-on treatment like a major trauma patient. So same processes for any major burn. So children or elderly over 10%, you'll get your widespread inflammatory response. You also will get inflammation that affects their airway. And in children, that can compromise it even more. So if you're given fluid resuscitation in children, that can accelerate the rate of edema formation and airway obstruction. So be very mindful if you've got unprotected airway in a child and you're giving them fluids because they are a major burn, even if it's not affected their face or their neck or their chest, if it's other areas of the body that are affected, actually you could have airway edema that compromises their airway. We already said that in children, the breathing, so if you've got a deep burn that affects the front of the chest or the side of the thorax, potentially that could affect their breathing, because in children, breathing is principally diaphragmatic. So they breathe off their middle, and that's what they use to try and expand, rise and fall of their chest. But once you have a deep burn that covers anywhere near the diaphragm, it becomes inelastic. The burn itself is very inelastic, and they'll have ventilation problems. They tire very quickly. So they compensate, and all of a sudden, that's it. They're done. They're in respiratory arrest. So actually, you need to look out for your ventilation problems, the result of the burns that are affecting that diaphragm area. The delays in fluid resuscitation can also cause problems. They can compromise care and outcome for children and elderly. From a size assessment, we already said that the percentage TBSA, when you're charting, children have massive heads, tiny bodies, and tiny legs. So majority of their TBSA is in their head. In a baby, front of the head is 9.5%, and the back of the head is 9.5%. That's a whole substantial chunk of body size that's taken up. And if they've spilled something on their head, it's going to be a major burn. So very much caution with estimation of TBSA. As a result, if they've got a big burn, they'll have high evaporative water losses and higher heat losses. So they're more predisposed to hypothermia. Children are much greater risk of hypothermia when you're applying first aid because of that higher body surface to volume ratio. And you need to have preemptive measures where you're cooling the burn, but keeping the rest of the patient as warm as possible. You need to take these proactive steps. So look after the thermoregulation in your pediatric patients. And it's the same for elderly. Elderly are just as susceptible. So as we age, our dermis thins. So we get much thinner skin, which is why elderly tend to get a lot of skin tears. So your dermis sheds, and it can get a much deeper, a bigger burn. But equally, if you're delivering cooling, they can get hypothermic more quickly. So you need to be very mindful of the fact that you're just addressing the burn injury, you're cooling the burn, but the rest of the person needs to be wrapped up and mollycoddled and kept as warm as possible. So just look after them. So those are kind of the differences that I foresee in children and elderly.
Yeah, indeed, indeed. One of the things, one of the revelations I had is these are, especially within pediatrics, because opening the back of an ambulance to a screaming child and a really distraught mother or father, because there's always a second patient involved, and they feel equally as guilty or more guilty because that they've it's happened on their watch, and it's there's all those feelings there. Is the human factors and the human factors of trying to put a plan in place when and verbalize a plan A, plan B, or plan C when there is a screaming child and you just can't think straight. And so my guidance was always, or my practice was always, step out of the ambulance or indeed off scene, share the mental model, because especially with kids, especially with some of the more stronger analgesics, ketamine, morphine, or fentanyl, or the stronger doses, just share the maths with someone else, because pick the phone up, call the emergency operations center or the critical care desk, or someone that you can share the load with. Just cross check and then step back into the scenario, because there's nothing worse than rushed maths, which can be incorrect. And there's nothing worse than overdosing a sick pediatric just because of the adage of you feeling rushed, which can lead to, like, say, medication issues and further issues down the line. So it's almost giving yourself permission to take yourself, and again, in the emergency room, in the resus bay, although it's, you might have to step out and step completely away, cross check the maths, cross check it with a colleague, and then verbalize a plan B and plan C. And sometimes perfect is the enemy of just good enough, which is they won't swallow anything. Like you said, the IM route is the only option available right now because they're screaming, they're wriggling. But once you've got some semblance of control and they've calmed in some which way, then look at getting more formal IV access on the back of that. And also, one of my revelations really was anxiolysis. So just anxiolysis with midazolam. Midazolam isn't a formal pain management drug. It really is more easing anxiousness. But so it shouldn't be seen as a definitive treatment, but multimodal and combination therapy but judicial, because it is quite strong. Midazolam, diazepam is quite strong and plays with the hemodynamics, but can just take the edge off that human factors, can just stop that screaming that environment, so that actually you can have more of a semblance of control, semblance of
One for
foreplay.
parent and one for the child.
Yeah,
Because
exactly.
actually, children feed off their parents, and the anxiety and the stress that the parent displays, children will look at them, think, well, mummy or daddy are so upset, so I need to be upset. And if you manage the parent, actually the child will calm down. And a lot of our pediatric burns nurses, the advice that they're offering, and the emergency department nurses, and also pre-hospital care practitioners, say if you manage the parent and you get the parent to do a lot of the interventions, obviously non-invasive stuff, but if you get the parent involved and if they're willing and are collaborating with you, actually the child calms down much quicker. They're more likely to listen to the parent or do as the parent does, and the distraction factor of parent interacting with child actually really helps calm the whole situation down too.
Which is powerful, actually, and it's really important to double click on that, Krissie, actually, because, like you said, you can get on scene and or in hospital. The team which negates the parent, there's a real deficit there, because, like you say, you're negating the primary caregiver and that important relationship which has been fostered over years, and actually vicariously calms the patient down through the patient, so that if you see a deficit in the, like you said, in the communication to the parent, that's the time to step up and really channel the care through the parent, to the child. You're right, it brings the temperature, brings in the scene down. So just as we're kind of coming to land on part one, actually, Krissie, we've actually broached pain management quite nicely, just different modalities of pain management. If I could just, as we finish off part one, we'll come back for part two later. Could you speak to some fluid resuscitation protocols, some of the recommended fluid resuscitation protocols for burn care that you advocate and or practice?
So my first thing would be avoid formulas. No formulas are required in pre-hospital environment. What you do need is ideally 2 large bore cannula in non-burnt skin. So that's your first challenge, is how you're going to get fluids into that person. So you need to find a site that's ideally unaffected by burn. Also, when you've got the transport to the burn service that maybe is within an hour, potentially fluids are not so important, but if you don't start them, then someone else won't start them, and then it kind of, you almost are acting as a prompt, like we've started and ED can continue and then rework it. So to avoid any delays in getting fluids into patients, the advice is maybe, just start something, but ultimately no formulas. In the burn services, so in hospital, we will use Parkland formula, which is the kind of the golden standard for us. It's best practice, but it's not overly suitable for pre-hospital care community because it uses the need for you to know the patient's weight and to accurately estimate their total body surface area burnt, which is hugely unlikely in the pre-hospital setting. The trauma estimation of size is hugely inaccurate, and we know that. So if you are basing a formula on all of these parameters that you're guessing, your fluid resuscitation is going to be over and under or somewhere in between, and ultimately it's unnecessary time spent doing complex maths. So ideally we don't do that. JACALC, which are the paramedic guidelines in the UK, they advocate that paramedics deliver a litre of saline to a casualty who's over 10% in children, over 20% in adults. But ultimately, you can only give a litre. So again, the size estimation almost, for me, is pointless. Doesn't matter if they're 60% or doesn't matter if they're 30%, if your capacity is only to give a litre of saline. So your estimation should be, it's a big burn, I'm going to give fluid, let's shove it in. And pretty much that's in the pre-hospital community. I would say just start it. And by the time you get to the hospital, it's dripping in and we can estimate how far you've got with that fluid resuscitation. And once they're in emergency department, that's when I would expect them to work out the Parkland formula, the weight of the patient, the accurate estimation of size. Faculty of pre-hospital care give you an option of a threshold method, fluid administration. It's a new method for me, so don't quote me, I'm not an expert. But basically, in total sum, it's a grid that allows you to estimate the fluid requirements in bolus terms, based on estimation of size of the burn, age of the patient, and the weight only. So for all burns over 20% in adults or children, which is slightly confusing because other formulas ask for children over 10%. So this one, faculty pre-hospital care, stuck to 20, so nobody gets confused. For adults and children, you will deliver whether the patient is 50 kilos, 75 or 100 kilos, and you give in a boluses of start off with 500 mils, 750 or a litre. So again, you can only give a litre max. So I would say start your litre as soon as you can, as soon as you've got access, and then let the hospitals work it out. A lot of time is wasted in the pre-hospital setting, either working out fluid formulas or size of the burn, and none of it is actually necessary and doesn't change your practice. It's either a small burn, a non-complex burn, or it's either a massive burn that needs fluid refill. Shove your litre of saline and let's go.
Listen, that's fantastic. That's fantastic, Krissie. Just as we come into land on this session on part one, could I get you just to speak to some salient take-home messages for listeners, just from some of the stuff we've covered? We've covered some really profound ground. Actually, we've covered a lot. But yeah, just some maybe some just take home messages for part one.
So your patients that you're looking after with burns are a trauma patient with a burn, not a burn patient with other trauma. And that's a really important approach to take from the off. Your A to E assessment, as you would for trauma, you can't go wrong, but bearing in mind that you know that each one of those steps, A, B, C, D, and E, will be complicated by the local and systemic processes that the burn injury kicks off from the time of injury. And it will be evolving with edema, difficulty in access, difficulty in calculations. All of these things will be incredibly challenging and potentially would also hide other trauma because of the visible and essential nature of the burn injury itself. It's an assault on your senses. Also, don't forget the very, very basics. Basics done right are actually going to save your patient. Also, some of the basics, like delivering appropriate first aid, knowing that you only have a 3-hour window to do it, and quite often once you get them to A&E department, it is not done, and by the time they get to the burn service 6 or 12 hours later, it's pointless to do it because it's no longer effective. So if you could save not only a life but also impact the quality of that life saved, would you do your 20 minutes cooling? Would you keep the rest of the patient warm? Make sure you mitigate for heat loss, knowing that they have no way to thermoregulate themselves because of the massive skin surface areas. All of these basics, treat them like trauma patient, be very wary of progressive edema and look after toxic damage from smoke and systemic damage, so airway breathing. Get your access, get your fluids in, keep them warm, and deliver them to the next service, and make sure all of that is part of your handover. There are very easy wins in this, and pain management probably would be my main takeaway, is that you're not going to get anywhere far, and actually you would make the patient's outcome worse if they're in a stress state. You're not managing their pain. Their wounds are going to be worse, more likely to get infected if you don't manage their pain. Did you know that? That's a direct link to wound healing. So give pain relief. Everything else becomes much easier once you control for that.
Listen, that's fantastic. And we'll see you in part two for another fantastic conversation. We'll look at some of the wider reaching aspects of burn care, but it's hugely informative and just fantastic just to get your insights and understanding around some of the fundamentals of burn care. So listen, Krissie, thank you so much for the last hour.
Thanks so much for having me. It's been great.